Good morning and welcome. I'm excited this morning about our plenary session. It's on the topic of appropriate utilization and ASCP's involvement in the Choosing Wisely campaign. You may have heard a little bit about this last night when we discussed it with the Secretary of State. But first, I'd like to introduce you to someone I've had the great pleasure of working with over the past year, our outgoing president, Dr. Joel Schilling. Under Dr. Schilling's leadership, ASCP has successfully launched formal collaborations across the world and with the United States, several major medical societies, in order to expand our educational resources and, of course, our services to our respective members, you. Under his guidance, several new initiatives have occurred. We've launched that protected strife to make sure the patient is always at the center of every decision we make. Notably, ASCP has joined the Choosing Wisely campaign, a national monument of activities related to expanding the conversation about appropriate test utilization and the high cost of health care here in the United States. Dr. Schilling has been a dedicated volunteer to ASCP for the past 40 years. He served in many significant leadership capacities. Since 2007, he's joined the ASCP Board of Directors. And in addition to his leadership responsibilities at ASCP, Dr. Schilling serves as the medical director of Quest Diagnostics in Portland, Oregon. Please give a warm welcome to our distinguished president, Dr. Joel Schilling.
ASCP's journey to healthcare solutions beyond the laboratory. By way of a little story, Odysseus is the Greek name for Ulysses, who was the Latin equivalent, was returning home from Ithaca, the site of the Trojan War and the Trojan horse. It's the most famous literary journey. For 10 years, Odysseus is buffeted by forces intent on thwarting his progress. Yet Odysseus, the cunning strategist, prevails because he stays one step ahead of those who try to delay, halt, or kill him along his journey. Likewise, every organization has its journey, navigating through hazards and obstacles to reach its goals. ASCP is no exception. We have our obstacles also. However, successful organizations like the ASCP have strategies that allow us and them to navigate obstacles that would knock them off course. In the 21st century, ASCP obstacles are very different from Odysseus. And of course, ASCP members' goals are different. To achieve the best outcome for patients, to do this, to accomplish this, ASCP and our members need to overcome obstacles such as changing the bloated healthcare system into one that can be sustained. Second, providing personalized medicine at the right cost, resulting in the best outcomes for patients worldwide. Third, finding multi-pronged solutions to the current workforce shortage of lab professionals and anticipating the impending workforce shortage for pathologists. And finally, fourth, forging alliances, both nationally and internationally, with the right organizations to accelerate progress and strengthen the resources of ASCP and those organizations with whom we join. First point, knowledge, developing a sustainable healthcare system. Each year, our country spends nearly $300 billion on unnecessary medical tests. Some of these tests may not only be unnecessary, but they may compromise patient care. Pathologists and laboratory professionals have a responsibility to question and to educate the physicians and other caregivers who are responsible for ordering these tests. ASCP's leadership for pathology in the Choosing Wisely campaign is designed to curb overutilization of laboratory tests. Earlier this year, ASCP announced its 5 initial tests for physicians and patients to question. And over the next 2 years, we are deepening the impact of the Choosing Wisely campaign locally through a grant from the American Board of Internal Medicine Foundation and the Robert Wood Johnson Foundation. To accomplish this goal, we selected the state of California, where ASCP, in partnership with the California Society of Pathologists, and we are going to promote Choosing Wisely initiatives with an educational and public relations program. Our approach reflects the evolution of healthcare and is driven by the axiom, right test, right patient, right time at the right cost. Speaking of the right cost, we need to make certain that our government is honest when putting forth proposals. The 2014 physician fee schedule proposal from CMS, in our opinion, is misguided and could compromise patient care. This proposal seeks to reduce Medicare payments to our community, the pathology community, by an inordinate amount and must be revised. Our members have responded to CMS and to Congress through a robust advocacy action. More than 10,000 messages have been sent through our ASCP Advocacy Center to CMS and the Congress, urging them to prevent implementation of these catastrophic cuts. Second point, advancement of the profession, providing personalized medicine at the right cost for the best patient outcomes worldwide. Pathology informatics holds great promise for personalizing medicine, reducing costs and saving lives. Additionally, it is crucial that pathologists and laboratory professionals join the multidisciplinary teams that are starting to direct patient-centric care. Their input on patient diagnosis is critical. On the policy side, the Supreme Court invalidated the patents on hereditary breast and ovarian cancer genes, BRCA1, BRCA2. ASCP was one of the 20 original plaintiffs in this long-fought case. The decision in June of 2013 was a victory for ASCP's contention that isolated DNA is a product of nature and a law of nature, not an invention, and thus is not patentable. We expect laboratories nationwide to expand genetic testing and offer more competitive pricing for these genes and the gene products. Researchers will now have the freedom to develop alternative assays, giving patients the option to obtain a second opinion. The third point, collaboration. Finding multi-pronged solutions for the current workforce shortage of laboratory professionals and the impending workforce shortage for pathologists. As the only society that represents the entire laboratory team, both laboratory professionals and pathologists, ASCP wants to ensure both professions continue to thrive and appeal to young people deciding on careers in science. The 2013 Task Force on Laboratory Professional Workforce has developed several recommendations based on the collective knowledge of laboratory professionals, program directors, and pathologists. These recommendations include promoting the role of laboratory professionals' interaction with patients, healthcare providers, healthcare administrators, and policymakers as an integral part of the multidisciplinary healthcare team necessary for the transition to a sustainable healthcare system. Second, engaging in science, technology, engineering, and mathematics. You heard of STEM last night from Hillary Clinton. These initiatives and other organizations and individuals to support and promote the development of high-level skills critically important to the performance of quality laboratory testing and management, and to bolster the pipeline of potential candidates for the profession and leadership in healthcare. And finally, pursuing a legislative and regulatory agenda that increases interest and access to training that leads to careers in pathology and laboratory medicine. At an ASCP Pathologist Workforce Roundtable recently, participants launched discussions of issues such as increasing the exposure to pathology for medical students, such as a required pathology rotation, training residents to be leaders in genomics by the ASCP, defining the complementary roles of pathologists in clinical science with doctorate degrees working together in the laboratory, and finally determining the role of pathologist assistants as extenders of pathologists and as teachers to residents about grossing specimens. The fourth point, global community. Forging alliances with the right organizations, nationally and internationally, to accelerate progress and strengthen the resources of ASCP and those organizations. ASCP recognizes that our society can do more for our members and for our patients. When we collaborate with the right organizations, we are stronger together. When we forge alliances with organizations that share similar visions, values, goals, and strategies. Building on the momentum of the past year, ASCP has forged alliances with the Association of Pathology Informatics, Association of Clinical Scientists, and Labs Are Vital. The alliances with the Association of Pathology Informatics and Association of Clinical Scientists are improving education for ASCP members and those association membership. Our participation in Labs Are Vital brings ASCP into the international realm to support lab professionals worldwide and to extend the lab's influence within healthcare communities. ASCP is working collaboratively with international partners that include WASPOM, the International Federation of Biomedical Laboratory Science, and the International Federation of Clinical Chemistry. Also, in the international arena, ASCP is removing obstacles for patients in Botswana to receive better health care in the laboratory through participation with the Botswanian Ministry of Health and the Bush Institute. In this area, our goals include, number one, expanding the lab's capabilities through new laboratory equipment. Second, training more laboratory staff, especially histotechnicians, to process the tissue and make the slides. And finally, providing diagnostic support through ASCP volunteers using whole slide imaging. From the ASCP's journey to Botswana and the solutions we are providing with our partners, let's return to ASCP's successful journey during the past year. We have made considerable progress through initiatives such as choosing wisely, investing in the partnership with the Association of Pathology Informatics, and identifying strategies to improve the root cause of workforce shortage in laboratory medicine and pathology. Truly, we have exemplified the idea of being stronger together with multiple partnerships, with enhancing the ties between pathologists and professionals. Our journey is not over. It is a continuous and shows great progress and promise. And like Ulysses, known as Odysseus in Greece, I know that despite hazards and obstacles through the journey, ASCP will continue to dynamically grow and provide positive influence for the future of the 21st century medicine. Thank you very much. Okay. I am delighted to welcome you to this fascinating session that Dr. Lee Hilborne has put together on the topic of appropriate test utilization, a subject that is critical. It's of critical importance to our pathology and medical laboratory community. But first, I would like to say it has been a pleasure and a privilege for me to serve as your president for the past year. And I would like to share a few thoughts about the future of this great organization. And now, I am pleased to welcome my friend and colleague, Dr. Lee Hilborne, a former president of ASCP and 2011-2012 chair of the ASCP Institute Advisory Committee. As part of ASCP participation in the Choosing Wisely campaign, an initiative of the American Board of Internal Medicine Foundation, Dr. Lee Hilborne led the ASCP panel that recommended 5 specific tests or procedures that are commonly ordered but not always appropriate in pathology and laboratory medicine. Today, he has brought together 2 leading pathologists who have been at the center of the national appropriate test utilization debate. He will share with his guests the unique perspective on ways to reduce medical testing costs. Please join me in welcoming Dr. Lee Hilborne. It's all yours.
Good morning, and thank you so much for coming to this session. It's a pleasure for me to be part of this session and to share with you much of what we've had the opportunity to learn over the last few years as we've been thinking about this. So today we really continue our discussion of how important it is for all of us in pathology and laboratory medicine. And I always worry about that topic because when we say pathologists and laboratory professionals, I always thought pathologists were laboratory professionals. But I'll accept that for now. Anyhow, as we certainly know, and it's certainly been the theme of this meeting, that our healthcare system is moving to a new model that really looks to maximize efficiency. And there will be changes in delivery and reimbursement that will be coming in the very near future. But the important thing, no matter how we approach it, or the reimbursement issues, or whatever, doing the right thing for patients is always going to be what's most important. And that really is all of our calling in our profession. And to do that, that really depends for laboratory medicine, since it influences so much of healthcare. That depends on our laboratories and our laboratorians being part of doing the right thing. So the challenge to all of us is to lead when it comes to diagnostic services and do our part to advance patient-centered care, as we heard about yesterday, to improve overall healthcare quality, and to reduce unnecessary utilization. So with this, I certainly would like to introduce then our panelists that will be here this morning. And I would note, at the end, we will be down in the Science Connection to sort of carry on the discussion, since we won't be able to do it here in this room. So I'll be talking a little bit about Less is More, the Choosing Wisely campaign. We've asked Dr. Gary Procop to talk with us about when more is less. Dr. Procop is a professor of pathology at the Cleveland Clinic and chair of the Department of Molecular Pathology and responsible for molecular microbiology. He's undertaken a number of initiatives specifically to encourage the patient care team to make wise decisions about laboratory testing. So we've asked him to share that with you. And second, Dr. Elaine Jeter is a Medicare medical director. And she's been with Palmetto GBA for about 8.5 years. And I've come to know Elaine really quite well working on some of the molecular pathology initiatives. She's an anatomic and clinical pathologist with subspecialty certification in blood banking and transfusion medicine, and has been on faculty as well as in the private practice of pathology. So I'd like to welcome Dr. Procop and Dr. Jeter to join us here. So I'll start briefly and talk about when less is more and the Choosing Wisely campaign. As was already said, it's an initiative that was undertaken by the American Board of Internal Medicine Foundation, and we're very fortunate that ASCP was asked to lead the initiative for pathology and laboratory medicine. The goal really is to engage in conversations that will reduce the overuse of tests and procedures and support physician efforts working with their patients to make smart choices about healthcare. Certainly that's the underlying goal of what we're all about in laboratory medicine, and certainly that's an underlying premise that's very important to ASCP. We know that there's lots of inefficiency in healthcare. And the IOM, the Institute of Medicine, reported that 30% of US healthcare is either duplicative or unnecessary. Paul O'Neill, who was in the previous administration, recognized this also when he was CEO of Alcoa. And Mrs. Clinton repeated this last night. So inefficiency threatens our nation's ability to deliver the highest care as possible, what we know is possible to our patients. So ASCP and choosing wisely. We ASCP, working together, identified that lab professionals and pathologists need to play a very key leadership role in addressing these challenges, particularly, but not exclusively, related to laboratory medicine. So why did ASCP join the Choosing Wisely campaign in 2012 and announce earlier this year their 5 tests? We acknowledged, and ASCP was a loud voice, that laboratory professionals contribute to improving patient care and reducing the high cost of health care, and that unnecessary testing also equals inappropriate treatment decisions and consumption of finite resources. So doing the right thing is the right thing. We also heard last night that healthcare spending costs are really out of control, and as this slide demonstrates, the United States being on the far right, that although we spend far more than any other country, that we don't get what other countries get from the healthcare that they deliver. So there's a key opportunity for us to look at both controlling costs and improving what we do. Also, so along those lines, the US ranks 6th, last, when compared to 6 industrialized countries: Australia, Canada, Germany, the Netherlands, New Zealand, and the UK. They have better patient outcomes than the US. I had a more detailed slide, but for this purpose, I thought to take it out. But the current amount of spending threatens Medicare, Medicaid, other budgets, and really strains families' budgets and businesses who fund much of healthcare's ability to cover the healthcare costs of their employees. So Choosing Wisely is one initiative that really seeks to reverse this trend, to reduce the costs of services that really provide no benefit to patient, and in fact address early some of those tough decisions about how care is going to be delivered in the future. We want to take charge of appropriate test utilization. That is our responsibility, not just to do the tests, but to be stewards of what should be done. So the labs really need to report information clearly and concisely to patients and to our clinical colleagues so that they can make the right clinical decision. So that better communication between labs and clinicians results in better outcomes. And we're working very hard in that area. When we talk about test utilization, there's a number of different dimensions that are relevant. The 5 tests that ASCP recommended to Choosing Wisely are one important dimension of that test utilization question. And patients should learn firsthand about these tests, and of course many others, so that they can make informed decisions about what to do. So Choosing Wisely experts, and I use that term loosely. The ASCP Institute Advisory Committee, as was mentioned earlier, spearheaded the selection of ASCP's 5 tests for Choosing Wisely. The panel actually did a literature search and reviewed hundreds of options on both the practice of pathology and the available evidence that supported the use of those tests. The 5 initial tests were selected to be illustrative of common situations that we confront, not to be the be-all and end-all, but really the beginning. And while we didn't select the most common tests, all of the items are not necessarily the most common tests, we thought it was important to illustrate the kinds of questions that we need to think about going forward. Specifically, tests with merit in some circumstances, but are not appropriate in others, tests that have no clinical utility, tests that have been generally replaced by better tests, and new and emerging diagnostics. So again, we envision this as being the beginning. I'll just share with you the 5 tests. The first test: do not perform population-based screening for 25-hydroxy vitamin D deficiency. First of all of us are in this room not getting any vitamin D right now. And so one of the things is that we recognize that many people have somewhat low levels of vitamin D. There are clearly clinical indications for testing for vitamin D, but population-based screening, probably not. You know, I would wait, you know, if you assume that you're working most of the time indoors, that you have more pigment in your skin, for example, wait till you get one of those sales ads from the big box store and go get some vitamin D and take it. But it doesn't necessarily mean that there is no indication, but in fact, population-based screening probably is not warranted. The second example is a test that really has no clinical value. There's no clinical utility. You don't do anything with this information. Low-risk HPV testing. Clearly, we recognize the value of HPV testing, high-risk HPV testing in patients and the incredible advances that have come in this diagnostic area with respect to women's health. But low-risk HPV has no clinical implications, and you don't do anything with the results. And so that's an example of a test that, frankly, shouldn't be done. A test that's probably, again, used too much, but for which there are reasons, is that we suggest avoiding routine preoperative testing for low-risk surgeries without a clinical indication. So high-risk surgeries where you really need to know what's going on, yes. For patients who have a bleeding history or a family history, yes. But for routine, very minor procedures, there's no need to get a urinalysis and common blood tests, again, in the absence of a clinical reason to do that. The fourth example, only order methylated septin 9 on patients for whom conventional diagnostics are not possible. So for those of you who don't know, methylated septin 9 is a new molecular diagnostic test to identify people at risk for colorectal cancer. The test has performance characteristics that are fairly similar to the guaiac test or the fecal immunochemical test. It's certainly more expensive. And the use is really for somebody in whom you really don't have a way to effectively do those other tests. So when those other tests are available, they really do represent the wiser choice. And lastly, a test that really has very much been replaced by other diagnostic, better, more specific diagnostic tests, yet it's still done in some hospitals, is the bleeding time to guide patient care. So for all these tests, we published information. It's in an ASCP review article that's available to you, a JCP review article with references for why we made the decisions we made about each of these 5 tests. Certainly, as new genetic testing is rapidly entering the market, and my colleagues will talk more about that, this is another area for us to consistently and constantly be thinking about helping our clinicians make the right choices about which of those tests to use. So diagnostic tests are a critical link with patient safety and quality. I ask all of you, and you'll hear more about this, I know, from my colleagues, to ensure that there's a valid medical reason to order a particular test and know how that test result contributes to guiding patient management. And it's okay to ask, why is this test necessary for this patient? Are there better alternatives? Perhaps including an alternative to not do any testing. And there may be options, there are certainly times where we know that our colleagues will order a test as opposed to some information that can probably be just as well or better identified from a history and physical examination. So the next steps, to educate clinicians and patients about when they need to consider these 5 tests, to examine locally for all of you, to go back to your laboratories, to your hospitals, to your practices, and determine whether there are other choosing wisely priorities based on local practice that will be important for you, but also let us know at ASCP, because again, those 5 tests were just the beginning, and so we want to move forward, and your input's going to be critical to that. And really to become not just the individuals who perform the test, but really consultants for effective test utilization. So we're in this together, we're stronger together. It's a challenge really to all of us to facilitate the use of most appropriate tests and treatments for every patient that we see. It is our challenge really to eliminate 30% of the care in the US that is really not appropriate, and make sure that we add the voice of, laboratory professionals, which include pathologists, to the conversation of improving patient care while reducing costs. With that, I'd like to certainly turn the podium over to Dr. Procop to talk to us a little bit about when more is less. Dr. Procop?
Thanks so much. I appreciate the opportunity to be here for the invitation from both Lee and ASCP. I have a little bit of time to tell you about a long journey, so we're going to go fast. I do not have anything to disclose, and I had to cover why more is less, and that actually, I didn't pick it, I was given that, but it fit perfect, so thank you. And this really talks about more intervention. I mean, this is the active part of this talk, and this is what you have to do if you are not already involved in test utilization at your place, is you have to get involved. You have to get on committees, you have to be places, you have to communicate professionally, and you have to talk people out of these unnecessary tests and tell them why in a professional manner. If you tell somebody that it's stupid to order that test, that conversation's over, right? So you have to have a meaningful and rich conversation where you can bring them around to your way of thinking. So more intervention is going to lead to fewer unnecessary phlebotomies, and that's actually how I got into this business. We were investigating how we could decrease unnecessary phlebotomies due to duplicate testing. And we wanted to do that because we were very concerned about iatrogenic anemia. As you know, if you're in the hospital a long time, too many phlebotomies, what happens when you're not carrying enough hemoglobin? You do have effects on wound healing. You are at greater risk for infection. So these are really patient care issues. We wanted fewer unnecessary tests, so more intervention, fewer unnecessary tests, lower costs, of course, and your administrators love that. And the one thing I like to think about that's not immediately obvious is fewer false positive reactions. So if you've already tested a group or a cohort of people with a test that has a high negative predictive value, you basically have a group of people who probably don't have that disease. If you retest that population with a test that's less than 100% specific, your positive predictive value has already dropped because your prevalence of disease in that group, by definition, is less. So the positives you get are more likely to be a false positive, is more likely to lead you down a false path. So what we did when I was assigned this, we looked around, we said we need to build a team. How are we going to build an effective team? And I think this is a pretty decent roadmap. I think it's critically important that you have a physician leader, and I would argue a pathologist as a physician leader. And the reason that is if this is run by administration, it's all going to be, the physicians are not going to accept it, it's going to be bean counters are at it again, et cetera, rather than a doctor that's concerned about implementing best practices, et cetera. You need leadership support. So this should begin with conversations with your chief of staff, chief operating officers, et cetera. Our team is open. Everyone's invited. I send out invitations to all of the institute and department chairs and invited them to send representatives. People that had heard about it, they've come and joined, and so it's an open team. What we do is transparent. It's multidisciplinary. We have input from many different disciplines in the hospital. The other thing that we have found that is just absolutely key is active support and partnership with your information technologists at a high level. And so these are going to largely be, most of our successes have come through interventions with computerized physician order entry. We're at a time in history that is new. It has never been possible in the past to interact with a clinician at the point of test entry. It is now. And so you can do that electronically, and again, you have to do that wisely. If you send too much pop-ups in front of these people, they just quit reading them, and we actually have evidence of that. So you're going to be able to interact with the physician in real time, and I think one of the things that I love most about our team is you're going to see a lot about how much money we saved. None of us are in that for that reason. It just happens to be something easy to count. Everybody on that team is interested in implementing best practices, and they're all patient care focused. The other thing that we've done that I think is really has worked out well is we monitor what we do, and we report back to medical leadership to demonstrate our success. I think this is critically important. So many times when we implement something in the laboratory, be it a new test or a new process, it just goes. We never monitor, we don't report back, et cetera. When we do report back these successes, it actually builds our credibility for the next, project that we want. The other thing we do is we share successes. I'm merely a facilitator to this group. This is a team approach, and every time I'm in front of medical operations, I make sure to point out what a great job IT did or somebody else that supported that team. So it's a lot about the emotional intelligence in a social situation that helps these things be successful. How do we start? Well, there was a time at the Cleveland Clinic when we were actually told, and doctor orders that you do it. And believe me, that doesn't feel very good as a laboratory professional. And so I give my boss a lot of credit really challenging this to our CEO, who asked her, do you think you should actually tell me what kind of test to order? And she said, yes, I do. And so that started a dialogue, and we had a proposal that we would like to stop duplicate test orders. And so what they made me do is they made me do a study, gather some data, which was actually very good. And so basically we call it a soft stop. We put a best practice alert in front of the doctors. It basically said, this test has already been ordered once. You usually don't need another one of these. Do you really still want it? And we had really two interesting findings. One was, our first pilot was for quantitative CMV and EBV PCR. So we knew the duplication rate for 3 months before the intervention, did the intervention, studied it for 3 months after, and we were thrilled to find that they were reading our intervention and they are not ordering the duplicate test. So we had a big celebration. We moved on to C. difficile PCR, and we had exactly the opposite findings. It was like they were just blowing through our alert. And we think what this probably is the first test is a relatively rarely used test, only used by specialists, et cetera. And we think they took time, actually read it, and did the right thing. C. diff PCR, C. diff testing, every intern has that on their list with a patient with diarrhea, and they were just too busy, didn't care, and burned right through our alert. This, however, gave me the data I needed to actually ask the question is, can we tell doctors no if it's appropriate? So if we have tests that we as a group practice say should never be ordered more than once per day, your ferritin's not changing today if you've already had it measured once. And so if we agree to this, can we tell them no? And they said, again, they made me wade into the pool. So what we did was this was our hard stop initiative, and listed here are some of our other initiatives that I'll touch on briefly. So for the hard stop initiative, we basically were allowed to do this for 10 tests, but I had to build what we call a break the glass scenario. If the doctor laid on the floor and kicked and screamed and cried, I still had to give it to him. But I said, I'll give it to you if you call our client services and you tell me who you are, why you want it, and who you work for. And so that was our break the glass scenario. And so this is what it looked like. And in between the invention of the hard stop from the soft stops, our IT people, and they get all the credit, came up with a great idea. Is they said, not only can we tell them this test is already in order, you don't need another, how about if we grab the previous result and embed it in the report? And the docs just like that. They're looking for a ferritin, so give them the last ferritin that was just ordered. So this has been really well received. So they made me start with 10. We put in 10. No one called and yelled at me. We were going to do another top 10, and one of those happened to be a serology test, and I just said, aren't all serologies about the same? And so that's how we got to an odd number like 78. It went live. And then I told the chief of med ops, I said, I'm going to be an old man by the time we're done in this manner. So he said, go for broke. And so we actually have more than 1,200 tests on the same day hard stop list. And the number of complaints have been very few when we rolled that out. This is what our graph looks like. Top graph, the blue bars demonstrate how many times they hit the button trying to reorder a duplicate test. That's actually evidence that they're not reading your alert. The red, so we only count our cost savings the first time this occurs. So we believe our numbers are real. And then the purple line at the bottom is the number of times they call client services for a break the glass. And so the green line gives you your true number of stops. So this clinical decision support tool is about 95% successful in stopping same-day duplicate tests. And you can see the numbers there. You know, in fiscal year 12-13, this thing stopped over 6,000 duplicate orders. So that was pretty good. This is what happens. Benjamin Franklin said, a small leak sinks a great ship. And so these are small changes every month, but this is your cumulative, right? And this thing's been built, it just runs. It's running right now. Right now, someone's getting a hard stop while I'm here. I'm not having to do anything. So you get the idea. We are implementing systems level changes that go on in perpetuity. So these are inexpensive tests. You can see, even though we're blocking a whole load of tests, cost avoidance is only around $100,000 a year, and you can see our total to date from when we started. But we really are proud of this, and it was a great success. The other thing that we did was we asked the question, we said, and this is how we framed it, we said, only oncologists give chemotherapy. There are certain drugs restricted to infectious diseases. Do you think that an intern that's fresh out of medical school should be able to push the button on ordering a chromosomal microarray when, you know, one person in the department can interpret it? Well, the answer obviously is no. So we introduced a restricted use initiative where we asked, who are the deemed users? Who are the people that use this and are knowledgeable about this in our practice? Those are the only people that can order it. So now if anyone else orders that, they will actually get a block alert that says, this is a restricted test, you can't have it. If you want it, you need a consultation with medical genetics. You can see not many tests are blocked because there's not a lot of these, but they add up, right? So in 1 year, $402,000, and since the inception of the program, $651. So this has been incredibly successful, and very few complaints. I was everybody's best friend when we were determining who was deemed users, though, let me tell you that. I never ate so good. No, I'm teasing. The other thing we did in conjunction with this was we employed a laboratory-based genetics counselor. So this person every day is present to actually do post-analytic analysis of chromosome microarray, complex sequencing. So she has a day job, but she also has a phone right there. And so she actually will review our daily send-out list and take calls, and this is her activity. So again, we're monitoring this activity, reporting back on it. I put back an annual report every year to my chair and our chief of staff. And you can see here that in 1 year, last fiscal year, 456,000, and then since this started, 644. So again, very successful. This young lady paid for herself in the first 2 months of being on campus. Then we were asked, can we share this with the regional hospitals? Well, this was much more complicated because our regional hospital system, although owned by the Cleveland Clinic, only about half of the practicing physicians there are Cleveland Clinic docs. So it was easy on main campus there. It was kind of a captive audience, right? So I had to really kind of walk the political line here. And so what we did was we built something we call a smart alert. It was a compromise, and believe me, you have to make compromises. I'm talking to our Republicans and Democrats if you want to move forward. And so this was a compromise. It's not the best way I'd build it, but it got it to move forward. Essentially what it was is it was like the soft stop, but with the embedded information in it. So the doctor can click through this. It tells them it's already been ordered, tells them they don't need it. It gives them the last result, but they do have the power to click through it. And so this is a report I get every month on this group, and you can see, although it's not 95% like the hard stop is, here on this one hospital I have 56% compliance with the alert, 44% blew through it. But this is 56% we weren't getting in the past. So we can look at the half full if you like. And so again, we monitor this. This is only 4 months old, but I have to say, it went live throughout our health system. No one has called me and yelled at me. So again, you get the same story here. Small savings added up across all the regional hospitals. You know, it gets to be a decent little number, so that's good. The other thing we did was expensive test notification. There's just a paper, I think it may have been in JAMA, that looked at Johns Hopkins, and they also found this to be effective. I was actually surprised this was effective as it was, because we already had the restricted use initiative in, What I didn't think about was all the tests that the hem-onc docs order themselves for malignancies in long-standing patients, MDS, et cetera. And so that's where we really got most of these savings. And so basically this just tells this doc, do you really realize that test is over $1,000? And we basically put these in $1,000 increments, over $2,000, over $3,000, et cetera. So when we looked at, this is for last fiscal year and my last annual report, our cost avoidance was about $1.3 million for all of these initiatives. And again, once these are implemented, they're rolling. They're all rolling today. So in conclusion, this is really a call to action. If you don't have a test utilization committee at your place, it is your time. This is the time for pathology leadership. And so start one if you don't have one, and if you have one, get more involved. So I think the improvements in test utilization really are designed to enhance patient care, promote our best practices without alienating our caregivers. I mean, this is where really the communication and the professionalism comes in. All the great things we started with, we're still in that for. Decreasing unnecessary phlebotomy. No one likes being stuck more than once. That increases patient satisfaction. Metrics that are being measured. It really is appropriately using limited resources and, again, decreasing costs. I think we're in a pivotal role to be leaders. Pathologists and other laboratorians really have an opportunity. So begin one today, revigorate, and really get involved at the systems level. Thank you. It's my pleasure now to introduce Dr. Jeter.
Ladies and gentlemen, it is an absolute pleasure to be here. And I want to thank the CAP, and I also want to thank Dr. Hilborne for inviting me to be here. So I was assigned the topic, when more is more and less is less. Very interesting. So let me begin by saying we have never had more diagnostic and treatment choices. We've had no data. We've never had more data about the natural causes and the courses of disease. We've never had more information about clinical effectiveness. We've never had more transparency in pricing, and the dots are because we could do a lot better, and I know you're all thinking about Medicare and the gap fill process and all of that. But we've never spent more money on unproven diagnostics and therapeutics. So less is less. We must be prudent stewards of the healthcare resources. We have a finite amount of money to expend on healthcare. I recently heard that it's just not too many years from now when healthcare expenditure will actually exceed our GDP. We have to consider efficiency, that's, you know, what's the best test, and then effectiveness, what it actually, it provides the very best result. We have to select diagnostic markers that optimize treatment choices, and we have to strike the right balance. When I talk about right balance, I'm going to ask you some rhetorical questions. Do we really need to do the whole genome to manage my daily healthcare needs? Most common diseases can respond best to common sense. The second question, how much screening or risk assessment do we really need for conditions that have no proven treatment? So from here, I can't begin to tell you what a great job Dr. Hilborne and Dr. Procop have done, because they have the same concept as that I have had in multi-specialty utilization teams. My approach is a little bit different because I base so much of my decision making on what is in the scientific literature. And there is an abundance of information out there so that organizations like the ASCP and CAP actually can work with clinicians and, for that matter, Medicare physicians to develop testing algorithms. We need to educate physicians and clinicians on assay utility and the utilization, appropriate utilization of these assays. One of the things that you can additionally do in the laboratory is to eliminate on the test requisition form the little box that is comprehensive, that includes all of these unnecessary tests, and require that the ordering physicians or the ordering clinicians actually provide very specific orders. Another method could be eliminate inappropriate assays from the requisition form and your test catalog. Obviously, this is what my two predecessors have been talking about. It is the responsibility, I believe, of the laboratory physicians working with a multidisciplinary team to actually come up and say, okay, folks, you know, that's an archaic test. There is no need for this to be done. You know, the example is, and I'll show my age when I use this example, CKMB versus doing a troponin. I mean, you know, it shouldn't be even available in the work of a person with chest pain. The other thing that can be done is review annual numbers of services per physician. I think if physicians were aware of their ordering practices relative to their peers, you know, cardiologist to cardiologist, that type of thing, they would be made aware how some of their practices, their ordering practices, deviate from other people. I think it's important in the laboratory that a laboratory performs assay cost analysis for helping in the determination of whether to keep the assay in-house or whether it should be sent out as a reference. And finally, I think that the clinicians and laboratory physicians should try to resist when a clinician threatens that they will send their testing elsewhere. I cannot believe how many times people in the audience have told me, well, a cardiologist said that he's going to send his, all of his testing 2 blocks down to the street, the other hospital, if they didn't, if the laboratory didn't offer this in-house. This is a business decision. It has to make economic sense. One of the things now, and I have to talk about what is a Medicare benefit because it has amazed me how many people are not aware that the Medicare program does not pay for everything. Medicare was originally established as an acute care healthcare benefit. So traditionally, it has never covered screening. Now, the screening that is available today in the Medicare program has to be statutorily determined by Congress. So the PSA that is performed as a screening, the pap smear that is done, the mammogram, and the colonoscopy that is done is statutorily determined by Congress, but all other screening is non-covered. Risk assessment without the signs and symptoms of disease is a non-covered benefit. So let me give you an example. The woman who has breast cancer, she's a Medicare recipient. She can have the BRCA testing, the BCR1 and 2 testing done. And it is a Medicare benefit, and Medicare will pay for that. But if her sister, who is also of Medicare age, has that testing done, that is not a Medicare benefit. If she does not have cancer, signs and symptoms of disease, if you are screening, if a physician is screening, and again, I cannot tell you how many times I've been before a group of oncologists and they said, but we always do it. Always doesn't make it right. It is not a Medicare benefit. Another thing that is occurring that we see in the claims processing is confirmatory testing is not a Medicare benefit. And when I say that, if the clinical history in serologic or whatever, imaging, whatever, proves a diagnosis, then to do the molecular testing just to reconfirm is not a Medicare benefit. So you say to me, well, Elaine, how do you guys find that? We don't. We don't. If they come through on a claim and they have a legitimate CPT codes, those pay. But does that make it right just because they pay? QC and QA has never been a Medicare benefit. We have had a number of molecular labs that are out marketing heavily to do confirmatory testing on GI specimens and urology, prostate biopsy specimens. Those are not Medicare benefits. And anything that is investigational and not part of a clinical trial is not a Medicare benefit. So where am I going on all of this? On overutilization of testing? I'm going to just use an example. And you see, I see it now. I was a pathologist. I did bill for insurance claims and everything when I was in practice. But now I'm on the other side, and I see things that I think are inappropriate. And one is in anatomic pathology. So you have a diagnosis of an undifferentiated malignant neoplasm. This is a tumor of unknown origin, if you will. So the pathologist in the hospital maybe does up to 15, 18 immunohistochemistries, and they're not able to nail it. They're no further ahead. And so doing 15, 18 immunohistochemistries is an expensive proposition. So then they send it to an expert, and the expert then does, you know, a consultation, and that's billed and paid. And then I see anywhere from 12 to 15 to 18, sometimes 25 additional immunohistochemistries. Well, so I do realize that the expert may be using different companies, antibodies that they're more familiar with, and to a limited degree, I accept that and everything. And then finally what happens, it's still an undifferentiated malignant neoplasm, you're no further ahead, and they finally send it out to one of the companies that does molecular diagnostic testing for tumors of unknown origin, which adds another $2,000 or $3,000 or $4,000 to this. You've now got about a $10,000 bill. And so what I'd like to leave you with is a thought that maybe the initial, when I was in practice, we used 7 screening immunohistochemistries, and if you got a good idea of maybe where you need to do initial 2 or 3 or 4 more, that you would go that route. But maybe after the initial, if you don't have a clear indication where to go, maybe it ought to go direct to molecular testing. And I think that this is one of the ways that, in fact, utilization committees within the laboratory, a multidisciplinary team, could help make that decision. Here's another in the clinical laboratory where I see claims, and that's the point of care drug of abuse testing. So just an example, you have a patient who's an attention deficit, an individual, they're on amphetamines, and you know, the individual admits to cocaine use. So you screen by EIA or immunoassay for, and amphetamines and cocaine are both positive. So the standard is you confirm or perform quantitation on the positive only. And yet we have laboratories that are out there marketing, you know, and they will perform confirmation on all the negatives. This drives up healthcare cost. Can we stop it? No, we can't stop it from a claims point of view because it's a legitimate test on a legitimate claim with a legitimate ICD-9 diagnosis code. We can't stop it, but you folks have the ability to identify and to see these things and to stop these kinds of behaviors that are all adding to the healthcare cost. So those people who know me know I'm the lady of clinical utility. And as laboratorians, you all are familiar with analytical and clinical validation. Basically, what are the components of the assay? How did the assay come about, its development? And does the test do what it's designed to do? That's fine. That's only part of, as we go into the next phases of coverage and reimbursement in the Medicare program and with all other payers, is this component called clinical utility. What is the evidence that the test improves patient outcomes? Because if it doesn't improve patient outcomes, then what's it for other than driving up healthcare costs? So I can't leave the podium without giving you a little bit of history, because I'm sure everybody has heard about the MolDX program. We kicked it off in California about 1.5 years ago. CMS, Medicare, funded that with Palmetto to come up with a process to identify every molecular assay performed in Jurisdiction 1, which happened to be California, Nevada, and Hawaii, but predominantly was in California. And then on all new assays coming to market before claims were ever submitted, they had to submit a technical assessment for review of did they have clinical utility. Now we use subject matter experts that do the clinical utility review. Many of them, because of the nature of the molecular assays, are medical oncologists. On every review, there are 3 medical oncologists that review the clinical utility and submit written information back to me, and then I compile the information and then submit it to the lab. But the important point is that it is the data that is driving coverage, and it is also the data from the laboratory and from the medical community that supports the reimbursement. If the laboratory and the particular assay can show significant savings to the healthcare system, then we are being allowed to reimburse appropriate to that healthcare savings, which is unlike anything you've ever heard anybody associated with Medicare ever saying. So with that, I think we're actually going to have questions after we break, but I would like to leave you with a thought or two that, you know, the more is more data drives coverage, and more data drives reimbursement. And for the less is less, absence of clinical utility will get you no coverage, and absence of clinical utility will get you no reimbursement. Thank you so very much, folks.
Ladies and gentlemen, please welcome back to the stage Dr. Schilling.
Thank you, Dr. Hilborne, Dr. Jeter, and Dr. Procop. Dr. Jeter explained how to pronounce her name. Meter rhymes with Jeter. Very helpful. Thank you. A very enlightening discussion. One more round of applause for our experts. And now it is with great privilege and pleasure for me to present the prestigious ASCP Patients Advocate Award to 2 individuals whose commitment to public health has made a difference in the health and quality of thousands of lives. The first recipient, Dr. Thomas Frieden, is currently the director of the U.S. Centers of Disease Control and Prevention at CDC. A physician with training in internal medicine, infectious diseases, public health, and epidemiology, Dr. Frieden is especially known for his expertise in the tuberculosis control area. Dr. Frieden worked for CDC from 1990 until 2002. He began his career at CDC as an Epidemic Intelligence Service, EIS, officer at the New York City Health Department. From 1992 to 1996, he led New York City's program to control and reduce cases of tuberculosis. The city's program became a model for tuberculosis control throughout the world. It fostered public awareness, helped to garner public funding, and reduced overall incidence of the disease by nearly half. Dr. Frieden contributed and continued the fight against tuberculosis on the global stage, assisting government of India implement a nationwide control program that resulted in 8 million patients treated and reducing the death rate to 1.4 million lives saved. He returned to serve as New York City's health commissioner in 2002 and spearheaded tobacco control programs that reduced the number of smokers by 350,000. He was appointed as CDC director in 2009 and led the nation's response to the H1N1 influenza pandemic, recognizing and supporting the essential role of the laboratory. For his distinguished service, Dr. Thomas Frieden is being honored today with the ASCP Patients Advocate Award to recognize the contributions he has made to advance patient care nationally and internationally. Accepting the award for Dr. Frieden's behalf is Dr. Nakasinghe. Thank you. It's indeed a pleasure. Would you like to say a few words? All right, I'll hold it for you.
Thank you so warmly. And Dr. Frieden said I should say to you that it's an honor for CDC to partner and continue to partner with ASCP for lab issues. What he didn't say I should tell you is my personal view. Dr. Frieden is truly a champion for laboratory medicine. He's a champion for evidence-based public health supported by laboratory medicine. So it's an honor truly to represent him to receive this award. Thank you so much.
And thank you very much. You notice I'm checking the names this time. The second recipient is Dr. Doreen Magola-Masiri. Dr. Magola-Masiri is the country director at the Botswanian University of Pennsylvania Partnership and a lead physician for Women's in Health in Botswana. She attended the School of Medicine of the University of Nottingham in the United Kingdom, where she graduated with honors. She continued her training in obstetrics and gynecology, first in the United Kingdom and then in the Republic of South Africa at the University of Cape Town, where she also pursued subspecialties in perinatal medicine and cervical cancer prevention. During her training, she helped develop the see and treat approach for the diagnosis and management of pre-cervical cancer lesions. This method ultimately proved to be a very effective approach in resource-limited settings, and it allows women to be tested and treated on a single visit. See and treat is currently recommended by the World Health Organization for use in resource-limited settings. Dr. Magola-Masiri, Doreen to me, has also been a leader in issues affecting HIV-infected pregnant women. She co-directed the first prevention of mother-to-child transmission of HIV in her clinic in South Africa and assisted in the development of national HIV guidelines in Botswana. She is also currently spearheading an effort to strengthen anatomic pathology services in Botswana. For her distinguished service, Dr. Masiri is being honored today with the ASCP Patients Advocate Award to recognize her contributions made to advance women's health care in Botswana and other resource-limited settings. Dr. Masiri, would you come forward? Thank you.
Thank you so much.
Okay, now let's stay. Well, I don't know if you get the picture. Let's stay here and I'll say some more. Yes, go ahead. I'll hold this for you.
I think every day, each one of us, in a very small way, we do contribute towards improving the global patient care. And I think we do that because it is the right thing to do. And we certainly don't do it expecting any recognition. So I am truly and humbly honored to be receiving this award today from your esteemed organization. And I certainly would like to thank some of my colleagues and friends from ASCP, Dr. Schilling, Blair Halliday, Jeff Jacobs, John Tomaszewski, Max Dollar, and Shannon Castle, and Victoria Fabios and Lucy Beck, who've actually made it possible for me to come here. My organization back home and the University of Pennsylvania has actually given me the platform to do what I love. And the continuing and constant support and encouragement from my family has certainly given me the courage to stay the course. So with all that, I really would like to say thank you very much from the bottom of my heart, ASCP. Thank you.
Doreen, as you accept this Patients Advocate Award, you should know that you're in really good company. Past recipients included former First Lady Laura Bush, Barbara Bush, her daughter, Dr. Paul Former, and the late Senator Edward Kennedy and Senator Barbara Mikulski.
Well, I can truly say I'm very, very humbled to get this award. Thank you very much.
Thank you. It is a great privilege for me to present the 2013 awards to 3 laboratory professionals who have distinguished themselves through their exemplary service to the medical laboratory profession, their leadership, and their contributions to the field of laboratory medicine. As I announce each individual, please come to the podium to receive your award. First, Dr. Walter Oliveira. We'll do the picture first, and then I have some praise to give you. Okay, come up here. We've worked together for a long time. We took media training together, so we're supposed to know how to do it. Walter is passionate about the field of laboratory medicine and is a strong advocate for continuing professional development. Walter was a student at the University of Virginia back in 1990 when the director of the medical technology program encouraged him to volunteer as an ASCP state advisor. He has been an enthusiastic volunteer ever since, serving on numerous committees of the ASCP Board of Certification, where he is the immediate past chair. Walter is recognized and known as a dynamic leader at the University of Virginia healthcare system in Charlottesville, Virginia, where he's manager of the immunology department. It's my pleasure to present the award to Walter. Congratulations. You have 1 minute.
Excellence in management, that's just crazy. It should be called survivor in management some days, but I am deeply thankful to ASCP for the recognition. I am blessed to have the support of a wonderful family that allow me the opportunity to do what I love every day, and that's heal patients, because that's what we do in the laboratory. It's rewarding and it's meaningful. And it gets better because I have had the privilege of being accepted as a volunteer with ASCP and the Board of Certification and the dynamic staff there, where our mission is to provide excellence in certification of laboratory professionals on behalf of patients worldwide. And you distill it down, isn't that what stronger together really means? Where every role, phlebotomist, medical lab scientist, histotech, pathologist, and every discipline, immunology, blood bank, cytogenetics, and every partnership, ABIM, AMP, APF, CLMA, AGT, CAP, and every department, OB, pediatrics, infectious disease, when we all work together, the patient is stronger or healthier. And to me, that is what patient-centered care is. And it's summed up in those 2 powerfully packed words of stronger together. So ASCP, I thank you, I thank you, thank you.
Thank you, Walter. I'll ask Peggy P. Simpson to come to the stage. Peggy has set the standard very high when it comes to preparing for professionals, right up here, for careers in medical laboratories. While serving as chair of the ASCP Board of Registry from 1998 to 2000, and later as president of NACLS, she called for innovative, rigorous curricula, thereby ensuring that laboratory professionals would provide high-quality care for patients. Patients at the center of everything we do. Her commitment to excellence also carries over into a position as Administrative Director of Laboratories at the Danville Regional Medical Center in Danville, Virginia. Today, we honor Peggy with the 2013 ASCP Member Excellence in Education Award. Let's step over here so they can get a picture. Here we go. Thank you.
Hold it for me.
I'll hold it while you give your 1 minute.
I give my 1 minute spiel. I have been a medical laboratory scientist for 46 years. Walter called me an institution. And 25 of these years, I've had the privilege of serving on ASCP committees and boards. Every ASCP meeting charges my batteries, and my neurons just start clicking. I have shared what I've learned with my lab team, and I think it's made a positive difference for our patients. I'm very appreciative of this award. This has inspired me to keep on clicking. I should be retiring. But when you have had that ASCP charge, your enthusiasm for lifelong learning continues, and you want to share your knowledge. Thank you very much.
Well done. I'd like Cindy Johns to come to the platform. A highly respected laboratory professional, Ms. Cindy Johns has worked tirelessly as an ASCP volunteer for more than 30 years. An educator for ASCP since 1980, Cindy has risen through the leadership ranks of ASCP, and she has served as the chair of the ASCP Board of Governors of the Board of Certification. It was the Board of Registry when we did it, right. Currently, she is chair of the ASCP Board of Certification International Certification Committee. Also currently, she's a senior IT technical specialist at the Laboratory Corporation of America in Burlington, North Carolina. Cindy has earned the respect of her peers for her significant contributions to advance the profession. I'm extremely pleased, Cindy, to present you with the 2013 ASCP, yeah, get out of the light. You think I wrote this, huh? Lifetime Achievement Award. I'm a reasonably good reader. All right. All right. Thank you, Cindy. Congratulations.
Thank you very much.
You have 1 minute.
Well, thank you very much, Dr. Schilling. And the first thing I'd like to say is, first of all, it's really not fair to try to sum up a lifetime of opportunity to work with an organization that, as you all know, has been extremely near and dear to my heart. But since I don't want to be the one that's embarrassed and gets the hook to climb off the stage, I will try to be very brief. But first of all, I would like to thank ASCP, thank the member commission for this unbelievable award. It's hard for me to imagine, or have imagined, back in 1970-something, when I gave my first ASCP workshop, that I would be standing here before you to get such an unbelievable award. And I cannot thank you enough for the opportunity to have volunteered and to have been part of this organization. I still firmly maintain that this organization has given much, much more to me than I ever could give to this organization. Secondly, I would like to thank all of the unbelievable and exceptional people that are in the audience, the ASCP staff, and people around the country and around the world that I've been so very blessed to work with throughout my professional career. It is something that I just could not have imagined, and I really appreciate the opportunity. And thirdly, I would like to say that even though this is the Lifetime Achievement Award, don't think you're done with me yet. Thank you very much.
I would like us to give one final applause for these awardees. I have a few wrap-up comments and some housekeeping reminders. Thank you all for joining us in this program.